Hello, everyone. I'm Dr. Sheri Prentiss, and thank you for joining this particular session on Catch It Early, Manage It Well, a practical update on lymphedema care. Hello, everyone. I'm Dr. Sheri Prentiss, and thank you so much for tuning into this session on Catch It Early, Manage It Well, a practical update on lymphedema care. Now, let me start by saying that the most important update in lymphedema care is that early recognition and early intervention can change the entire trajectory of survivorship by protecting function, preventing progression, and improving quality of life. In about the next 20 or so minutes, we'll cover some practical evidence-based strategies for identifying risk, recognizing early signs, and for managing lymphedema effectively using conservative care principles that apply across settings. But before we begin, I want to share a brief. Hello, everyone. I'm Dr. Sheri Prentiss, and thank you so much for joining this session on Catch It Early, Manage It Well, a practical update on lymphedema care. Let me start by saying that the most important update in lymphedema care is that early recognition and early intervention can change the entire trajectory of survivorship by protecting function, preventing progression, and improving quality of life. I want to cover some practical evidence-based strategies for identifying risk, recognizing early signs, and for managing lymphedema effectively using conservative care principles that apply across settings. But before we begin, I want to share just a brief disclosure to ensure that there's transparency and alignment with CE guidelines. I am the founder of the Live Today Foundation, a 501c3 nonprofit organization. I have no commercial financial relationship related to lymphedema products or services. This session is educational only, and it does not endorse any specific product, brand, manufacturer, or supplier. And any garment examples or images shown are strictly for clinical illustration. Now, by the end of this session, you should be able to define early stage lymphedema, recognize risk factors, understand the prospective surveillance model, apply conservative management strategies, identify red flags and when to refer, and integrate equity-focused approaches in care. So let's start with what's new or what's changing, and this really is the update, and it's good news. We're seeing a shift from reactive care, meaning waiting for swelling, to early detection and prevention. Finally, baseline measurements and ongoing surveillance are now being recommended and incorporated into survivorship care. It's about time. And we're also introducing compression and self-management education earlier, as it should be. And care is becoming more multidisciplinary with oncology, rehab, and navigation all working together and not in silos. And importantly, there is a strong focus on equity because access to garments, therapy, and education directly impacts outcomes. Availability and accessibility are not the same thing. So this isn't just a clinical shift, it's a shift in how we think about survivorship care. So why does all of this even matter? Well, lymphedema is a chronic condition that can occur after breast cancer treatment, including surgery and radiation. And it is often under-recognized and undertreated in survivorship care. The concern is that if it is not identified early, it can progress, impacting function, increasing infection risk, and significantly affecting quality of life. And there is also a real financial burden associated with long-term management. In fact, research has shown significant financial toxicity, reinforcing that delayed care doesn't just impact health, it increases long-term burden. So the key message is this: early recognition and early intervention can change the trajectory of survivorship. So let's start with staging, because that's really important. Staging matters because management changes depending on where someone is on the spectrum. Stage 0 is considered latent. It's patients who may describe heaviness, tightness, some subtle changes without visible swelling. Stage 1 is starting to see some mild swelling, often pitting, and it may improve with elevation. Stage 2 is where swelling becomes persistent and fibrosis begins to develop. And stage 3 includes significant swelling, skin changes, and functional impairment. But the most important message here is this: stage 0 and stage 1 represent the best window for prevention, and in some cases, even reversal. This is the window where we still have leverage. And this is why I tell survivors, if something feels different, even if you do not see swelling, say something early. So let's talk about the early warning signs. Lymphedema risk, it varies depending upon the treatment you received for your breast cancer. And specifically, this session is on breast cancer-related lymphedema, okay? So the first step is understanding each patient's individual risk. From there, prevention really comes down to 3 things: early detection, a clear monitoring plan, and patient self-awareness. Baseline and follow-up monitoring allows us to detect changes early, often before visible swelling occurs, which creates an opportunity for earlier intervention. But just as important is what happens between visits. Patients need to know what to watch for themselves, like heaviness, tightness, changes in movement, or even some subtle swelling, because the reality is they'll feel it before we see it. So remember, early action prevents progression. Now, it's important to understand that lymphedema isn't just a fluid issue. Inflammation plays a key role in disease progression. A 2024 study in the International Journal of Molecular Sciences highlights that early intervention may do more than just relieve symptoms. It may actually interrupt the inflammatory process that drives disease progression. And this is what reinforces why surveillance, education, and early action matters. So, treating earlier stages isn't just easier, it may actually change the biology of the disease. Now, let's talk about some key risk factors. Oh, going a little too fast. I'm a little excited. But key risk factors include axillary lymph node detection, BMI greater than or equal to 25, regional radiation, certain chemotherapy regimens, whether or not the patient had any infections, did they develop seroma after surgery, and did they develop axillary web syndrome after surgery. It's also important to recognize that Black race and Hispanic ethnicity are associated with higher risk, highlighting the role of disparities in outcomes. So, risk assessment isn't just clinical, it's also about equity and access. So, let's talk about some key factors to consider. So, we see that risk is influenced by multiple factors, right? Including the type of surgery, patient factors, Black race, Hispanic ethnicity, treatment exposures, depending upon the type of chemotherapy, whether or not regional radiation was done, and post-treatment complications, as previously mentioned, that they develop axillary web syndrome after surgery. So, for example, axillary lymph node dissection carries about a 3 times the risk compared to sentinel node biopsy. And a BMI over 25 also increases risk. But the key message here is that low risk does not mean no risk, right? Every single patient needs some level of monitoring because risk is cumulative. It is not binary. Evidence-based consensus guidance is really about standardizing how we approach risk reduction. Aligning with ACS and LANA recommendations helps to improve consistency, and ultimately, by doing so, helps with outcomes. This figure here, and if you notice at the bottom of the slide, I do provide the reference to the particular journal article where this is pulled from. So please access that journal and pull this resource because it is meant to be practical. It outlines guidance for both patients at risk and those who are already living with lymphedema. So this is something that you can print out, give directly to your teams, and begin to implement immediately. Pre-treatment baseline measurement is essential because without it, we miss early disease. Data from the PREVENT trial shows that without a baseline, up to 71% of cases using bioimpedance spectroscopy and up to 88% of cases using tape measure may not be identified early if we do not get that baseline measurement. So this isn't just about measurement, it's about detecting change. And this baseline measurement approach aligns with updated NCCN guidelines, reinforcing baseline measurement as a standard of care. No baseline means no early detection, and no early detection means a missed opportunity. Let's talk a little bit about risk stratification, because risk stratification doesn't inform if we should monitor, but rather guides how we monitor patients, because not everyone needs the same level of monitoring or the same level of surveillance. But remember what I said earlier, every single patient needs some level of monitoring. Risk stratification is only delineating how much surveillance a particular patient needs. Using a shared decision-making approach helps patients to better understand their risk, and it actually improves adherence to the plan. This particular tool, again, the resource where it's derived is on the slide, so please look at the resource. Please get this risk stratification tool because it provides a practical framework to align risk level with surveillance and intervention. Really practical. And so when patients understand their risk, they're more likely to engage. That's reality. And that's what drives early detection. And patients can't understand their risk if we never inform them of their risk at the time of diagnosis or at least some time before treatment begins, because we need that baseline measurement. So remember, risk stratification guides care, but it is engagement that drives outcomes. Let's talk screening strategies. Screening strategies should be guided by risk factors, including the extent of axillary treatment, BMI, rurality plays a role, radiation, was it regional radiation? How much did they get? And taxane-based chemotherapy. But screening is more than just measuring limb volume. At about 3 months post-op, it's also important to assess musculoskeletal issues, shoulder function, and chest wall symptoms. And importantly, a good screening program will do 3 things. Clearly define risk level. It's going to clearly define the frequency of monitoring and when to intervene. So if you're only looking for swelling, you are already behind. Conservative management remains the foundation of lymphedema care. The core pillars are consistent. They include compression, skin care, manual lymphatic drainage when it's appropriate, movement, education, and structured monitoring. So what's changed in this regard is that we're applying these earlier and more proactively. And remember that the plan must be individualized based on stage, function, and patient goals. The greatest impact happens when we apply these interventions early, especially in stages 0 and 1. Early stage intervention is where these strategies make the biggest difference. As lymphedema progresses, both time and cost increase significantly. In subclinical stages, management may take less than an hour a day and remains relatively low cost. By early stage, that time increases, often requiring durable medical equipment, like the use of compression garments, maybe a pneumatic device, and rehabilitation visits, which increase costs. And in later stages, patients may spend 2 to 3 hours a day or more just on self-care alone, and may include custom garments, repeated therapy, and higher risk of complications, all creating a significant financial burden. But what this really means is time taken from a patient's life, time from work, time from family, and daily living. When you look at it over a year, that's about 2 weeks in subclinical stage, 4 weeks in early stage, and we're talking 6 or more weeks in later stages devoted to self-care alone. So the earlier we intervene, the less of a patient's life is consumed by managing the disease. Lymphedema prevention requires a dual approach. Patients should be empowered to ask about their risk. Therefore, it's important for you to understand what that risk is. They need to feel empowered to ask about their monitoring plan. Therefore, you need to have one in place. They need to know what symptoms should trigger a referral. You need to know which ones do, and how to access therapy and compression support. And I'll give you some resources in just a little bit. At the same time, this is a systems issue. As care teams, we need to ensure that baseline surveillance is in place, referral pathways are clear, and barriers to access are reduced. The goal is not just awareness. It's making early detection and intervention actually accessible in practice. Because early detection, it only works if patients can access what they need. Now, organizations like the Live Today Foundation and the American Cancer Society provide accessible survivorship and lymphedema education. And for clinical support, directories like NLN, Learn, and LANA, they can all help connect patients with certified lymphedema therapists. The goal is to ensure that patients are not just informed, but actually connected to the care and the support they need. Education 100% matters, but it is access that changes outcomes. So I want to leave you with the key takeaways. Stages 0 and 1, they represent the best window for prevention and early management. Compression is foundational, but it must be individualized. And let me repeat, every patient needs monitoring. Risk stratification merely determines how much surveillance a particular patient needs. Movement, skincare, and self-management are all essential for long-term success. You must know the red flags, and you have to refer early when symptoms change or persist. And finally, access and equity directly impact outcomes. So As we close, I want to bring us back to the core message. Lymphedema does not have to become a late life-altering complication. When we screen early, educate early, intervene early, we can change the trajectory of survivorship. Because remember, survivorship isn't the end of the story. And by changing the trajectory of survivorship, I mean we are preserving function and we're improving and maintaining quality of life. For clinicians and navigators, that means clear surveillance, early referral, and reinforcing self-management. For patients, it means knowing your risk, recognizing early symptoms, and speaking up. Early recognition and early intervention truly change outcomes, and that's within our control. Thank you so much, everyone, for all the work that you do, and thank you for your time and attention for this clinical care update in lymphedema management.